I'm going to go ahead and kick us off. Welcome, everyone, and thank you for joining us for exploring knowledge gaps on the front lines. Today, we're here not to just discuss data, methods, or investigative processes, but to also lift up the lived experiences and deep emotional weight carried by those who live and work at the intersection of climate, environment, and health. This webinar is rooted in the belief that frontline communities and frontline practitioners are often the first to see what the research world may take years to quantify. The studies we're featuring today were led by individuals who embody that intersection, clinicians, researchers, and advocates who recognize that the impacts of climate change and environmental harm are not just theoretical, but very present in the bodies and stories of every one of us. We're honored to spotlight the work of three remarkable speakers. Dr. Marsha Haley, a radiation oncologist and researcher, will present findings from a recent study that uses measurements of radium-226 to estimate community exposure to radioactive elements like polonium-210 and lead-210 near oil and gas infrastructure. This study is a critical contribution to our understanding of the invisible risks carried by those living near and working for extractive industries and the failure of regulatory systems to protect them. Rachael Hood, whose research involved 24 interviews and two workshops conducted in Ohio, Pennsylvania, and West Virginia to address how gas extraction, production, and distribution have disrupted residents' place attachment and how this disruption is emotionally embodied, causing not only environmental harm, but also physical harm. Dr. Pouné Saberi, occupational and environmental medicine physician and PSR PA board member, will provide commentary that connects these studies to the broader movement for environmental justice. Her reflections draw from years of experience both at the bedside and in the field, emphasizing the moral and clinical imperative to integrate environmental realities into patient care and public health strategy. These studies matter deeply to those of us working in this space of climate, environment, and health, not just because they advance knowledge, but because they give form to what so many already feel, that we're putting band-aids on what is a systemic illness. Whether it's the air we breathe, the water we drink, or the warming world we walk through, environmental harm lives in our bodies and in our emotions. These researchers have brought that reality to light, validating community voices and offering a path forward grounded in evidence, empathy, and justice. We hope today's conversation inspires you, challenges you, and deepens your commitment to research and practice that centers scientific integrity and human dignity. So let's begin, and we'll start with Dr. Marsha Haley.
Thank you. Can you hear me okay?
Yes, sorry.
Okay, great. Can you go back to my first slide, please? Thank you. So today I'm going to talk about a paper that was published in April in the Journal of Environmental Radioactivity. It's called Quantitative Environmental Radiologic Assessment of Oil and Gas Exploration Activities Using Radium-226 concentrate to estimate polonium-210 and lead-210 dose. So what does that mean? It means that we were interested in looking at the amount of radioactivity that is brought to the surface and passed along to people with oil and gas activity. So we wanted to see if we could measure that because there's not a lot of data in this particular area. Next slide, please. So the authors were Bobby Mannion and Dr. Bascaron from Wayne State, myself from University of Pittsburgh, Justin Noble, an independent scientific journalist, Tammy Murphy and Laura Dagley were both from PSR. Next slide. So we know that radioactivity exists as part of oil and gas operations, and the amount depends on the geological location. So the Marcellus Shale is quite radioactive, formation conditions, and the type of production operation. So with fracking, with the amount of fluid that's pumped into the ground, the salinity of the fluid and the withdrawal of the fluid to the surface, that brings norm or naturally occurring radioactive materials to the surface, where it's then called T-norm, technically enhanced natural occurring radioactive materials in the area of proximity to the gas industry. And our goal was to assess the potential exposure to oil and gas workers and to the public. And next slide. Our funding partners were Physicians for Social Responsibility and the Park Foundation. Next slide. So the types of sampling locations that we were able to access were public spaces. We tried to get as close to the infrastructure as we could. We had some limitations with that, which I'll discuss later, but we could sample creeks, public parks, public space near landfills, wellheads, near holding tanks, runoff ponds, pipelines, compressor stations, and old waste pond sites. Next slide. So for the analysis, if you look on the right, there's a diagram of the uranium decay pathway, and the elements that we're concerned with are radium, radon, lead, and polonium, which are daughter products of uranium. And we used modeling to estimate the dose from the source to the public, since we didn't actually have measurement devices for people. And we also used methods in the lab, including gamma spectroscopy, MATLAB analysis, and alpha spectroscopy to measure the radioactivity. Next slide. So we started out in southwestern PA in Washington and Greene County. If you live in this area, you know this is a very heavily fracked area. Next slide. This is a picture of taking samples from a public park. Next slide. This is a gas well site that was actively producing. They weren't actively drilling or fracking, but it was a producing well site, and we had access to the well site itself. So we were able to take soil samples up there near the condensate tanks, near the pipelines, and also in the runoff ponds. Next slide. Next, we move to southwestern, south central PA to look at several landfills in Westmoreland County. These are landfills that take fracking waste. Next slide. We were not able to directly access the landfills. They wouldn't let us on site to actually take samples, so we took samples in the soil and creeks near the landfills. And it's interesting that we actually did pick up some radon gas near these landfills, which is pretty unusual given the fact that it was a clear day with windy conditions. So one wonders what's actually being released from the landfills. It's a shame that we couldn't actually sample up there. Next slide. So then we moved to southeastern PA and Delaware County. And to do that, we know that the actual fracking occurs in north central and south and west and southwest Pennsylvania. And then the pipelines go across Pennsylvania, and then you have the landfills. The pipeline goes across to eastern Pennsylvania, and then the pipelines get pretty big over there, and then they go down to the Marcus Hook refinery, and then they're shipped offshore. So next slide. So I thought this was really interesting. This is a picture from inside an apartment building. This is a pipeline going right through this apartment complex. If this pipeline ruptured, the people would not survive in this apartment complex. I was amazed how close this is to where people live and work. And there isn't a lot of obviously a lot of rules around this, that it's this close. There for actual wellheads there are, but for a pipeline there apparently isn't. So I thought this was really something. Next slide. And this is the research group down at the Marcus Hook refinery. You can tell it was during COVID. Next slide. So looking at the overall sampling sites on the left side there, you can see south of Pittsburgh are the initial sites that we sampled. Just to the right of the end of the Pittsburgh is Westmoreland County, where the landfills were. And then as you come over to the right side near Philadelphia, those are the pipeline compressor stations and Marcus Hook facility. Next slide. This is an overlay with what I talked about earlier. You can see in the north and the west side and the southwest side of the state, that's where all the actual drilling is. And then the pipelines come across to the bottom to Philadelphia. Next slide. So to look at dose assessment, we first have to look at what are the dose limits for the public, because we have to consider the oil and gas workers public because they're not classified as radiation workers. So for drinking water, the limit is 5 picocurie per liter. That's the EPA limit. For radioactivity, we have 100 becquerel for the Nuclear Regulatory Commission and 370 becquerel per kilogram for the EPA. And the dose equivalent is 0.1 rem annually, or 2 MR per hour. And again, that's for a member of the public. For me as a radiation worker, my limit is higher than that. Next slide. So the conclusions of the study, when we did the measurements, we found that a soil core collected from the fence line of a compressor station contained the maximum radium-226 activity, and lead-210 concentrations in this core ranged from 98.4 to 142 becquerel per kilogram, which is a little higher than we expected. And we believe that this is due to oil and gas activity. And the highest activities that we found were in superficial waters near condensate tanks, compressor stations, and landfills. Not surprising. Next slide. So there is very little to no radium-226 from atmospheric fallout. So knowing that, we can take the atmospheric fallout minus the background, and that gives us the amount from oil and gas. So we found that about 35% of our samples, or 22 of 63, were enriched with radium-226 that we felt were from oil and gas. The amount did not pose a radiation health hazard to the public. However, when gas containing radon-222 is transported through long distance in pipelines, lead-210 and polonium-210 will be daughter products of that and will contribute significant amounts of radioactivity. And so oil and gas workers in certain parts of the infrastructure are likely to be exposed to levels of concern and should be monitored, in our opinion. Next slide. So the workers can be exposed by a variety of means, most commonly mineral scales when replacing pipe segments or doing pigging, and that's radon, lead, and polonium. Air at the wellhead during drilling or at compressor stations, and that's radon. Produced water spills and splashes, which is radium, and transmission of waste, which is radon. That's when the trucks are taking it to the landfill. And next slide. So the correlation with the other sources, we know that the radiation dose limit for workers is 5,000 millirem, and as you recall, it's 0.1 rem or 1,000 rem for a member of the public. EPA says T-norm can only exceed 1 MR per hour in an 8-hour shift, and that's 40 hours per week are 280 rem. And so if we calculate out what a worker could potentially get with 280 rem per week, that definitely would be over the limit that we would want for the public. And then when we look back at the PADEP data from 2016, 2017, they found very high levels in fluids, including 20,000 picocuries per liter radon and 350 picocuries per liter radon in the leachate coming from the waste. So if you recall, the EPA's maximum level of drinking water is 5 picocuries per liter. So this is very high numbers. Next slide. We did have some limitations of the study. We were unable to directly measure radon levels. So radon disperses in the air because it's a gas. So you have to kind of have it in a closed space, and we didn't have that capability. As I mentioned before, we were unable to directly access the landfills. We couldn't obtain flowback sample, pipe scale, and impoundment sludge, which were things that would be likely to have the highest radioactivity. We, of course, had limited time and access to the sites, and we assessed for radioactivity only. We know that there's a lot more to fracking waste, including endocrine disruption, respiratory irritation, and other health-related effects. Next slide. So future research could include actually collecting samples of those sites where there's likely to be the highest radioactivity, collecting samples while wells are being produced and drilled, sample fracking waste, collect samples closer to infrastructure, expand the study to include VOCs, BTECs, and other hazards. And something that I've been advocating for a long time is dosimetry or measurement of oil and gas workers for exposure. Next slide. Is that my last one?
Yes, it is.
Okay, thank you very much.
Thank you. We'll save questions until the end. Now I'm going to pass it off to Rachel.
If you could stop the screen share so I can
Yep,
switch it. Thank you.
there you go.
Okay, sorry, had a difficulty getting the slides up. Yeah, my name is Rachel. I got my master's in geography at West Virginia University in 2022, and I wrote my thesis about the emotional geography of pipelines in the Ohio River Valley. From that came this piece, which was written by myself, my advisor, Dr. Martina Angela Coretta, and then Chris DeGulio and Laura Snyder, who were participants in the research and are also, advocates and do a lot of documenting and advocacy work. And so the piece is called Disrupted Place Attachments and Emotional Energy Geography in Fracked Appalachia. And I'm going to be giving like a overview of what we talked about in that piece. And then when we get to the Q&A, I know PK's here. Laura might also be here. Definitely happy to have y'all jump in and share your thoughts and experiences as well. Woo! Sorry, drop my phone. Okay. So just to get started, some basic grounding from the literature overall. So we know from the literature that gas infrastructures alter landscapes significantly, and that can impact communities and their emotions. That said, technical energy research is overrepresented in knowledge production and application, and research that uplifts the lived embodied experiences of industry is not as often valued and incorporated into policy and decision making. So to date, there's been limited research at the intersection of extractive industry and emotional geography. So this research explores that intersection by investigating how the embodied emotions of gas extraction, production, and distribution have disrupted residence place attachments. And we argue that these processes are not only a physical construction, but also a system of unfairness and marginalization that materializes in embodied harms to residents. To orient in emotional and energy geography, what we know from emotional geography is that in addition to people affecting one another, feelings are also negotiated in relation to place itself. And this is often through what we call place-based attachment and place-based identity. So place-based attachment is a person's or a collective's connection to a home environment and the meanings associated with a place over time. And then place-based identity evolves from that, which is to say the formation of identity through a connection to a place. When these attachments are threatened or disrupted, ecological grief can result, in which mental health deteriorates from place-based impacts. And in addition to disruption, displacement, energy development can also result in what's called slow violence. So this is a term coined by scholar Robert Nixon to define gradual violence that's drawn out across space and time and not necessarily recognized as violence. Environmental contamination is very often an example given of this. So for example, scholars have written about Cancer Alley in Louisiana as an example of like modern slow violence from industrial pollution. And slow violence can lead to feelings of stationary displacement as residents are stuck in a place that's been stripped of its familiarity and habitability, but they are unwilling or unable to leave. And the photos in this, unless otherwise noted, were taken by Bill Hughes, who was a really prolific documenter and activist around the fracking industry. He passed a few years ago, and his wife, Marianne Hughes, very generously shared all of his archives with the lab that I was part of at West Virginia University. So in terms of how we did this research, we, as I said at the beginning, come at it from multiple positionalities. So Dr. Coretta and myself have studied pipelines in an academic context, and then Chris and Laura are fence line residents and also activists who are experiencing the everyday impacts of the landscapes. And this research, the material was gathered in 2021 through 24 interviews and 2 body mapping workshops. Body mapping is a method that asks participants to draw or trace their body and then illustrate their emotions and experiences based on questions. It's the method is credited to Indigenous feminist activists, including Lorena Cabnal, who conceptualizes the body as a living and historical territory and stresses that what happens on the land or on the territory is imprinted on our bodies through our memories and emotions. So from this, we can understand that there's a connection between the individual and the personal with larger systems of geopolitical power. And so for this research, participants were asked to draw an outline of their body and then respond to a series of questions. These questions were about the relationship between gas infrastructures, the landscape, and their own bodies and emotions. And then participants shared what they drew with each other and discussed it as a group. And these are some images from those workshops. The way that we bucketed the results of this research is into sort of 3 categories of place attachment and place disruption. So the first is about the self. And here we see that health concerns demonstrate how participants felt a loss of power and political authority in protecting themselves, which shifted their perceptions of their own agency. So half of participants reported already having health effects from the industry. And then they also reported a fear that they had already been or would eventually be affected by radioactivity and toxic chemicals, resulting in an illness without being able to demonstrate the cause. Participants also reported psychological health effects, including fear, anxiety, stress, frustration, anger, sadness, grief, and disappointment. In each of these sections, I'm pulling out a key quote from the piece that I think kind of demonstrates how we got to the conclusions of the piece. So in this interview, a resident was sharing anger that the FDA required Neutrogena to pull sunscreen from store shelves because it had trace benzene, but that it was deemed acceptable for residents to breathe in benzene emissions from a compressor station every day. So this person lived a few hundred feet from a compressor station. And this left them asking, why doesn't our life matter? Why doesn't our community matter? We are expendable. And I think that this story captures the anger of many participants at the living conditions, as well as the attitude of government officials who dismissed their concerns. And this disconnect between their lived experiences and a need for scientific proof in the eyes of authorities leaves residents and fence line groups with a disconnect between their lived experiences and the resources to talk about them. And so that sort of break between their experiences and how to communicate them results in a sense of place disruption and highlights the inequities and power imbalances of the process of resource extraction. The second bucket we talk about is the home. And I think this this quote is particularly powerful. We've got a stocked bass pond up on the hill. There's pastures, there's caves, there's nut trees and wildlife. It's just a bit of magic, but it's almost like a shroud has been laid across it. So when we're talking about slow violence and the invisibility of toxic pollution, scholar Tom Davies directs us to ask an important question, which is out of sight to whom, invisible to whom, because this slow violence is not invisible for the residents who are impacted by it, as evidenced by their lived experiences of their changes to their bodies, to their homes, to their communities, to their day-to-day life. And I think this image is just like a sort of a jarring contrast between like the rural landscape and the industry trucks. The last bucket we talk about is the landscape itself. So in this interview, when my aunt and cousin would come and stay with my parents, both of them told me that at 3 a.m. something would wake them up. And it wasn't something you could hear, it was more something you could feel. It's not just a structural presence. You can feel it, you can smell it, you can see it. It's enormous and it's overwhelming. So when we talk about disruption to place attachment and place identity, it's not just an emotional or a mental reorientation, but there's actually a physical sensation to it. And for participants, the landscape and the self are linked through that embodied emotional response to the changes to the landscape and the geography. So the conclusions we draw in this piece, more than a resource for extraction and extraction and production for fence line communities, energy is an effectual agent. And this research contributes data to how gas extraction, production, and distribution are imbued with and shaped by emotions. That's a quote from another piece about resource extraction. This study focuses on pipelines and extends the scope of energy geography beyond the site of extraction, so the well pad, to the associated midstream infrastructures, which have been historically less focused on in the research. So we show that sites of gas transport, including pipelines, compressor stations, and metering and regulation stations, have the capacity to disrupt place attachment and generate emotional upheaval, which expands our understanding of the damage beyond just the well pad, but to the entire energy network. And the ways that residents in the sacrifice zone felt that they were seen and treated as expendable supports the argument that energy systems are a physical representation of exclusion, marginalization, and uneven influence. We conclude by arguing that energy and emotional geography is an important lens through which to do a holistic assessment of the impact of energy systems, particularly to residents and communities in which these infrastructures are constructed. And I've linked different things that I've referenced here, but I just want to say thank you first and foremost to the participants in the study. Nothing would have been possible without them sharing their experiences and stories, and I'm extremely grateful to them, especially some stories were very difficult to share, and so I'm very grateful to that. Thank you to the Heinz Foundation for funding this research. Thank you to PSR for hosting this webinar, and also to the fellow presenters. I'm happy to be learning from you all as well. So that's what I've got. Thank you for having me.
Thank you, Rachel. And we'll pass it off to Dr. Pouné Saberi.
Great. Okay, and you can see my slides?
Correct.
Okay, great. Thank you so much. Thank you for, inviting me to be part of this, great panel. I've been loving the photographs. I have no conflict of interest to declare. This was not funded, and I'd like to acknowledge my co-author, Dr. Judith Green McKenzie. And so I'm going to shift gears a little bit. And the study that I'm going to talk about, it has to do with a workshop that happened. And we wrote about this workshop and kind of the educational tools that came out of it. So before I get started, okay, there we go. There's a lot of context to be kind of to describe for this, and The kind of the overarching context is the medical specialty, which is my medical specialty, that's occupational and environmental medicine. And I also want to make a plug for a webinar that PSR PA sponsored back in January, where we went into depth about this particular like what does it mean for what does a specialty mean and kind of the historical context of it. So for those of you who didn't watch that, please you can go ahead and take a look at it. Okay. So the kind of this medical specialty in the United States has an annual conference, and it's called AOHC. And so the workshop that we presented was the AOHC that took place in 2022 in Salt Lake City. And I had been wanting to I had wanted to create a webinar about how clinicians can really utilize the knowledge that they learn about climate change and apply it to health. Kind of several things converged. One is that we teach a class about climate change and health to medical students, and it was always a question for me, like, well, how are they going to know, like, how to apply this in a clinical setting? And then and then the fact was that there's going to be a particular tool that I'm going to talk about later that really kind of also set the stage for this workshop. And what I didn't want to do is I didn't want this to be a workshop where you just lecture at people. Definitely wanted participants to think about solutions. And I wanted them to, these like practitioners to feel confident about applying the knowledge, that they learn. So the structure of the workshop was such that we went through the science of climate change and how does climate change like link to like how do the pathways link to health, and then we divided the room into 6 groups, and there were 6 scenarios having to do with extreme weather events, and each group got one of those 6 scenarios. Then we'd had 10 questions, and they would go through these 10 questions to generate the discussion, and at the end would come up with 3 solutions. So that was the workshop, and when we then went on to oh, and then we would end the workshop would end with these kind of take-home points about each scenario, and then also these kind of practical tool at the end that I'm going to talk about. So the my co-presenter, who's Dr. Mackenzie, really encouraged us to write this up. It was a long process, but we've finally managed to write it up and get it published. And so this has been published in the Journal of Occupational and Environmental Medicine, or JOEM, and we had to come up with an infographic for it. And this is the infographic that was published. You can see those were the 6 scenarios that were discussed. And then we also mentioned, we did make a point about the fact that this particular specialty, there is more than just the interface with health because it's occupational medicine. There is a big factor having to do with how climate change impacts industries and labor in general as well, and why it's important for people to know about these things. So this was the summary of the results summary, and essentially I won't go into too much detail, but the survey asked the participants about what they've learned and how confident they felt about it and how relevant it is, and what they would have to rate it from 1 to 5. And most people agreed or strongly agreed with the fact that this was valuable to them. And then there was also invitation to write qualitative comments, which was really interesting. A lot of them were talking about kind of like how the knowledge helps them to advocate for more climate change education in the healthcare sector. And then one of the shortcomings about the study was that we didn't go into it. We didn't go into the workshop thinking that we're going to write about it. So there's things that we probably would have set up if we had thought that ahead of time. So for example, we didn't do a pre and post knowledge check as part of the workshop. Okay, so all right, so now I want to focus on this particular tool that I was talking about, and this also really provides part of the kind of the emotional push for me as to why I was motivated to write about it. This particular tool was as a result of many, many conversations with a very valuable PSR PA board member, Dr. Julie Becker, where we had in fact spoken at many times about kind of this translation into practice and about how like, you know, if people have, you know, kind of think that it's important, so that's behavior, and then learn about it, so that's knowledge. But then where does the shift to practice happen? And so there was a model that was called I Prepare that helped practitioners to ask about environmental factors. And so we thought, well, what if we created a mnemonic that asks about climate change factors? And so we created O Career, and each of those, you know, stand for obviously one of the headings that you see on the left-hand side here. And for each of these, there was questions that would elicit information from the patient. And so and the in order to help people how to use it, Tenny Verkaitis, executive director of PSR PA, helped us put this together on the website. And many of the board members, some of them might be present, you know, on the call today, helped to explain each of those categories. Why is it important to ask about each of those categories? And what would be some of the questions that would be asked about those categories? And so, for example, you know, like if they have the knowledge that fossil fuels is warming the environment, and warming the environment leads to extreme weather events, how might that guide the conversation that happens between a primary care provider and their patients in the clinic room, for example? And then this particular tool that's still on the website has a pre and post knowledge checks. It also has a certificate when all the modules are completed and finished, and then a certificate is given. So we went on to kind of take this tool a little bit further, and we created this handout where in addition to all the questions that you can see that have to do with each category, we added these codes, and the kind of the clinicians in the audience might recognize what these codes are. They're called ICD-10 codes. And the codes are a way of, number one, telling the insurance that this topic was, you know, addressed. And number two, for the practitioner, for the clinician to identify that they addressed these topics during their interview with the patient. And so this was kind of like a later addition that was made to our handout. And so the article came out in I believe January, and I never got to tell Julie Becker that it was published. I was very motivated to write about it because we had taken this tool to so like medical schools and insurance companies, etc. But you know, maybe he was ahead of his time. I don't know. It was not really picked up by anyone, but I wanted to write about it so that I could kind of like memorialize, you know, this as what we really believed in to be a really valuable, you know, clinical tool. And so, for those of you who know, unfortunately, Dr. Becker passed away in February, so I never got to tell her this was published. But this is kind of like, I just also want to, you know, recognize that this is in her memory as well. And so that is, I believe, my last slide.
Thanks so much. I really appreciate your presentations and the work that went into each of your research projects. I think that these projects are definitely a reminder of why research matters, but looking at it not just academically, but impacting environmental justice the way that all of these have, I think is something that more researchers need to be thinking about, especially when they're working in communities that have been impacted by fracking and other toxic industries. I really like the way that each of these tie back to a lot of the work that we're doing. Obviously, the work that Marsha Haley did was supported by PSR PA. We've definitely been very interested in radioactive emissions from oil and gas infrastructure, but we're also thinking a lot about what's happening in wastewater from oil and gas. Each of you highlighted, well, I believe each of you did, laborers as well. And worker safety is something that we're trying to bring to the forefront just because, as much as we care about communities, we can't forget the people that work in these industries being impacted by, bad regulation, poor protections, and then these people are taking these waste materials home with them. So these are leaving the site, entering communities, entering homes, and definitely sickening people. Um, Pouné's presentation obviously talked about O-Career, which was definitely a labor of love. Lots of thanks to the late Dr. Julie Becker for that. One of the things that I really appreciated about working on O-Career is the fact that we often talk about how do we bring climate education to practitioners, all different types of health professionals, and actually make it a part of practice, not just this little bit of theoretical knowledge that you learn in maybe one course over your 4 to 7 years of medical education. I really felt like O-Career brought theory to practice in by adding ICD-10 codes, because then if practitioners actually use the little cheat sheet that we gave them, used ICD-10 codes, that would actually become a part of someone's medical health record. And once that becomes the norm, or more people see that, then hopefully others would engage in the same practice. Our goal was to empower health professionals to champion the health of communities by adding these codes to their health records. And then Rachel's work actually touches on something that I've been talking about a lot. So when I saw this come out, I was really excited to see her work. We often think about how people's health is impacted, but we don't often talk about the mental and emotional toll. And for me, that feels like something that we have to bring to the forefront more often. We have children who are experiencing climate grief. Rachel talks about ecological grief and slow violence. And these aren't terms that I think people think of a lot when they're doing this work. We're so focused on the industry, trying to make sure that the DEP is acting appropriately. We see the humans and the health impacts, but I think we often forget that kind of slow psychological, emotional toll that this is taking on the individuals who are being impacted. So again, I want to thank you for centering the voices and the emotions of those that were and still are impacted by fracking and other toxic industries, and bringing that to the forefront so that more people can start thinking about this, not just health impacts. I think all of these presentations showed us the harms of environmental degradation, showed us that they're actually measurable. And I think it challenges us to think about how we can bring different disciplines into the work that we do, and how we can also bring the voice of those most impacted to the front of our conversations, and not just use them as guinea pigs when we're talking about what's happening in communities. These folks should definitely not just advocate for themselves, but be allowed to speak for themselves when we're talking about the different conditions that we come across. With that, I do want to open it up to questions. I wanted to just see if there's any in the chat or Q&A. I have a couple of questions as well. Let's see. We did have someone ask, and this question kind of goes to everyone on the panel, what your experience with the Pennsylvania DEP or EPA has been, if you've had any in the work that you're doing. And I'll just open that to anyone who wants to answer. I see Marsha, you're off mute.
Yeah, I've reached out to the DEP several times about monitoring workers for radiation. They have not been receptive.
There is a new bill out for that, but it doesn't have much teeth to it at all. So hopefully someone can come up with something better. Not sure if either of you wanted to comment on that. Okay.
I can just say that I not a lot of experience with DEP other than kind of the similar experiences to what Dr. Haley described. But with EPA, especially Region 3, we have asked them to do educational sessions for residents in occupational and environmental medicine. And historically, they had been very receptive to doing it. They would, come, like especially like ATSDR employees, they would come and they would do great presentations about kind of the interface between like the regulatory, and health interface. Unfortunately, somehow after the East Palestine incident, a lot of that kind of really changed. It was bizarre. And then specifically in this new administration, it's actually been worse. Like there's been really no they really haven't felt kind of able to come out and do any educational sessions. So I feel like it's gone from bad to worse in recent months even.
Yeah. I would expect that we'll just see it continue to go downhill. Unfortunately, it becomes our job. We're ready to
Yeah,
do it.
yeah.
Rachel, I have a question for you. How can researchers and public health advocates responsibly incorporate emotional testimony and place-based identity into environmental health research and policymaking? And I highlight responsibly.
Yeah, that's a great question. And I guess I have thoughts, but I certainly am not like a health practitioner. And would, be eager to see how health practitioners you know, interpret this study in terms of practice. But um I think really something that stands out to me is the fact that like the upheaval from construction and operation and the impact to day-to-day life is significant for many residents. And I think at times, and this is reflected in the story shared, at times it feels as though the focus becomes very individualized of like a person's overreaction to something or hypervigilance to something. And so that's an individual problem and not a systemic problem. And so I think something that is valuable is meeting impacted residents where they're at and recognizing that there are like these structural systemic issues and that it's not just an individual problem or an individual's experience, and that these are patterned. And from there I think you know a lot of what we end up doing on like the end of things is like harm reduction and like helping people manage through like what I and many would regard as like unfortunate unjust circumstances. And I think just valuing that there is significant impact, um and treating it as a like long-term chronic problem, rather than I think what has often felt like a very dismissive attitude to many of the participants when reporting to not just DEP, but like I had folks who were trying to call the Department of Health, especially because like these things were happening during COVID and people who had COVID were also breathing in the emissions from a compressor station and literally could not breathe in their homes. And so I think it, you know, in addition to these like regulatory agencies that tend to be dismissive, I think also as like health practitioners, valuing and like seeing it as something to support patients in living with.
Yeah, I appreciate your making the difference between individual versus systemic issue. Often, you know, there is that one or two, maybe three voices in a community, but when they're the only voices you hear over and over, they feel or are um, viewed as just being a squeaky wheel. When there's actually others out there who are experiencing the same thing, they just may not be as vocal, so then it just becomes those three people are experiencing it. That's not really an issue. I also appreciate your bringing up the DOH because that was a question that came up in the chat asking about the experience that anyone on the panel has had with the Department of Health. I know that we, as PSR PA, have done some work with the Department of Health, especially in Southwest PA, but I don't know if Marsha or Pouné, you have something you'd like to share there.
I have not worked directly with them.
I have not recently had any, and then also like, I feel like half of my experience really was focused on the whole fracking thing, like, 12, 13 years ago, but then it shifted to COVID 5 years ago, and it's like now, so there's kind of this, the arc of my experience with them is not all about, environment. However, there was that one handout that they came out that I was super impressed about, and they've done these kind of like environmental determinants of health talks that, so I don't really know if that's made them more kind of receptive to, the community concerns. I don't know that. But it's definitely like even the webinars and the handout is more than they ever did before. So the thing I wanted to say about the topic of kind of what Rachel talked about in that article is that I feel like as health practitioners, I don't know if we realize that there's actually, and when I say science, I don't mean science as in terms of hard science, but body of knowledge is really what I mean, like about emotions, because they seem so kind of like nebulous. And I feel like it's really important to have the perspective of, I don't know who the expert, social psychology, I don't know who the expert would be, like, some, people like, Rachel I'm not saying you're a social, I'm just saying like, that kind of field to really educate, the healthcare practitioners about the fact that there is actually kind of like a large body of knowledge, about this and validity to kind of understanding it.
Agreed. I think that people have been trying to train health professionals on trauma-informed care, which is like way out here. We haven't even zoomed into what we're talking about here, and you're not necessarily getting a response from this kind of like very, vague level. Getting people to care about individuals and communities is a completely different thing. But I think we can get there if we just keep presenting the material and find enough people who advocate and keep presenting it as well. Question for you, Marsha. Um, in terms of the findings that you had, do you have any immediate thoughts about protections or policy change that you'd recommend to reduce worker exposure to radioactive materials in oil and gas? You mentioned dosimeters. I did mention that there is this very loosey-goosey bill out there, but what thoughts do you have?
Yeah, I think that definitely measuring the dose, seeing what they're exposed to. I think if they're going to be exposed to the fluids, give them safety gear, the waterproof boots, waterproof, coveralls, things like that, that they don't get it on their clothes or against their skin. Common sense stuff. If you're going to be around a place that you think there's going to be radon, have some kind of filter. Yeah, it's just treat them like we would a radiation worker.
Thank you. I have a question here that either Pouné or Marsha can answer. Pouné, especially since you are teaching that course. Is environmental health a requirement in most medical school curriculum?
It is not. It's more of a specialty rotation. Dr. Saberi and I both have a master's in public health, so we have, specialized training in that. But in medical school, that's more of an elective than a core rotation.
Yeah. And again, I want to refer people to the webinar that we did because we did talk about that. And there's also the that radio show that we did where we describe this, but that kind of really talks about how environmental this kind of this rising awareness of environment as a determinant of health is a new thing. And so yeah, it's not established in the medical school curriculum.
So it needs to be right up there with SDOH. We can have EDOH.
Right, exactly. Yeah.
Pouné, how do you think that clinicians and public health professionals could better screen or track health risks in populations that are living near infrastructure? I mean, obviously we have this O-Career tool, but if they don't have that, what types of things should they be asking? And of course, I know you're going to point them to the webinar, which I put in here.
Yeah, so again, this kind of ties into the discussion about awareness of environment as a whole as a determinant of health. I think part of the frustration is that because there's so little knowledge about this, that there is a kind of a lack of recognition of the patient's concerns. And what I have, like 13 years ago, I advocated for this. 13 years later, I'm still advocating for it, that accurate documentation of what they're saying is like the first step. And rather than saying, oh no, it can't be that, like just like it's not for you to say whether like you're gonna need to document what they said about what they think it is, and the thing is that there has been a lot of advancement in kind of our understanding of it. And just because maybe it's not like exactly, it needs to be, for it to be like um, um, really concrete, science about it now, it doesn't mean that it won't be in like a year or two or three. So I would say that the first step is this accurate documentation that have to do with all the variables that have to do with it, namely space and time. So like, how close, and the kind of the timeline of their concern and their symptoms. I see that there's also a question about climate refugees and kind of with that. And so I want to refer Emily to the work that our PSR PA board members does, Catherine. She's a clinical psychologist who specifically works on the mental health impacts of climate change on adolescents. And she gives a really good talk actually in the course that we give on that and about this specific topic of kind of vulnerable communities. So.
And not to plug PSR PA, but we will be doing a webinar with Catherine Crow and other clinical psychologists on just this topic. So look for it this fall. I wanted to see if there were any more questions out there before I wrap us up for the evening. I also was just thinking about what you said, Pouné, and it's not like I'm here to promote AI, but one of the pros that have been presented in terms of using AI in a clinical setting is that it will capture everything that a patient says, whether or not it's considered important enough to write down in a health record. So whereas a physician is listening for very specific things that they're going to put down into the health record, AI is capturing everything so that evidence will be there later. So that's one pro, I thought.
There's a couple in the actual Q&A section.
Oh, sorry. Thank you. I didn't see those come in. I'm doing too many things at once. Okay. Why would NRC not be involved in creating these standards for radiation protection for workers since they have so much knowledge and experience in the area of radiation, albeit nuclear radiation? Has NRC done any work with TNORM in oil and gas?
So NRC oversees what when you take radioactivity and you use it for a specific purpose. So they oversee, let's say that we use radiation as an injection to treat bone cancer in some cases. So they oversee that. If you take a radioactive material and put it on the tip of a drilling rig to help you see, through the rock where you're drilling, sometimes they'll use that. The NRC will oversee that source. They don't oversee the oil and gas industry as a whole, and they don't oversee the waste product from oil and gas. So they're really not involved in that aspect of it. There are, the follow-up question was, were there any international standards addressing oil and gas and radiation protection for workers? There's sort of international standards for radiation workers. But again, we come back to that circle that oil and gas workers are not considered radiation workers, and so they're not monitored, so they don't come under those protections.
Thank you. I'd like to give the opportunity for any of our panelists to make a last comment if they're interested, not required. I just don't want to cut anyone off. All right. Well, thank you. Thank you to our panelists. Thank you to our attendees. This has been very informative. Hopefully, folks will take this out into their working life and think about how they can improve their personal research or share ideas for research, even with us here at PSR PA. We're always looking for people to collaborate with. Thank you so much and have a good night.